Okay. And we're also going to be doing trach suctioning, nasal pharynx suctioning, and also, not nasal pharynx, but trach suctioning, excuse me. Yeah. Okay. Trach suctioning and trach care. Nasal gastric tube intubation is a clean technique, not sterile at all. Last I checked, nasopharynx secretions are not sterile. Okay, therefore we're going into a non-sterile environment. You have seen maybe these type of tubes in the hospital. Little blue pigtail called a Salem sump, and I'll explain that. There are other types of tubes which are for feeding, enteral feeding. But today we're going relative to the different purposes of NG insertion. Decompression, that's removing gastric secretions which are therapeutic and which is a therapeutic process for the patient. An example of this is someone who comes in with pancreatitis. They're constantly producing secretions, but it's at a, yes. Bigger. Mm-hmm. Does that help your eyes? Yes. Okay. Purpose, decompression. You're taking fluid out. You're just like you're removing to alleviate pain or fluid production. An example I started to tell you, someone has pancreatitis. Constant production of pancreatic enzymes and other gastric secretions to the point that the person's nauseated, they're vomiting, there's no increased motility where the buildup of gastric secretions is not going through the GI tract. They need to decompress. Or someone who has a lot of not only the gastric secretions, but also flatus that is there. You want to decompress that person. How would you know someone needed decompression besides nausea and vomiting? What would you notice about the abdomen? Distensions.
You can hear them gurgling sometimes, right?
When you auscultate. Mm-hmm.
Even like up here.
What? When you do long sounds, you can hear that referred gurgling. Sometimes you can hear it before at the door.
Yeah.
Okay. Yeah. Don't be in straight view of them, though. Projectile. Another way of reason for nasogastric intubation is lavaging. I always remember this by thinking laboratory. You clean. This can be with lavaging. It could be somebody who comes to emergency room on Friday night, they had a party, and they ingested some unknown drug to do a testing. And you want to get that out. So you use our isotonic solution, normal saline. You try to lavage that area. But before that, depending on the medication they took, be it intentional or whatever, you may give some charcoal or some type of installation down the tube to neutralize that GI area, and you're lavaging. The preferred lavaging solution is normal saline because it is isotonic. Another rationale for lavaging is, say someone has an upper GI bleed and they're having blood clots and blood that needs to come out of the system. So therefore you are using normal saline again, you are irrigating in, and you're bringing clots out and old blood. Blood in the GI system is not comfortable for the patient because what are they going to do in response? They're going to have the illnesses.
Got it.
Okay, so lavaging. Gavaging is gastric, you're feeding. You're feeding the person. This is not the preferred tube for gavaging somebody. This is for decompression. However, in the clinical area, you might see someone that might have a tube, say on some, where that they're feeding, but it is not the preferred. For gavaging, you need a Levine tube. That's just a tube that does not have a pigtail. It is a tube where it has eyelets at the end for your Levine.
So the first one you showed, you said that was a Salem sump, and that's for
You
decompression?
could decompression because it has this air vent.
Okay.
Levine is just a straight tube, and there's various sizes. We won't get into that right now. Various diameters and lengths. And that's for installation of feedings. What are some different feedings you guys have seen put through a tube?
I haven't seen any.
Ensure, Jevity. There's some like relative to the disorder, like for respiratory, there's one Repro or something like that. Or there's a renal one too. It's specific to what's going on with that person. And usually someone who is getting a gavage is they have a problem with the GI higher stricture. They've had surgery, and the physician has determined that this person has a problem with absorption. So there's a Levine tube put down, and they get their feedings that way. Besides having a tube, the person may have a peg tube, and you're taking care of the person as opposed to esophageal gastro tube. Person may get feedings through that. Med installation is another reason. Say that person is getting all their feedings and their meds through an NG tube. One thing to remember, if it's for med installation, there's a process you must follow. And that is, first you want to check placement, which I will go over in a few minutes. Besides placement, you also want to make sure that you use that isotonic solution again, normal saline, to flush that tube once you determine placement. You give the med, whatever it is. It may be a liquid, or it may be one that you need to make a liquid by crushing your med and put it in a solution. Then you always end up with saline. Just like an IV, flush, med, and then flush again. With NG, med installation, and get in the habit with feedings also. Flush, feeding, flush. Okay, now, with any NG tube, there's different ones. Salem sump, as I stated, you know it, it's a blue pigtail and has an air vent. When you are instilling anything through the tube, it goes through here, not the air vent. What is this little thing for, some of you who work with people? It's a connection. You don't do this number, which I've seen done in the hospital setting. What have you just done? You've broken the action of this air vent. You always want to have this acts as an anti-reflux, meaning the tube, whatever in the stomach is coming out through this islet, going through here. Generally, this is just as they're walking, you would then clamp the tube and walk them. This is not the proper anti-reflux valve, but it's a connection. It's far better than crimping this and putting it in your tube. They'll look good. Anyway, the beam for feeding, and a dual tube. A dual tube I don't have here to show you, but a dual tube goes further than the stomach. It's a tube that same principle as a Levine, just straight tube, but it has a little bulb on the end. I don't know if your book has a picture of it. And you displace that tube with air, once you get to a certain area, you displace it down into the stomach. Pass the stomach to the duodenum. That's a duo tube. Placement and placement verification. I knew that. Look. You gave me face. Okay, what does your book say? Where's your first place for putting the tip of this tube? Nose? Where else? What part of the ear? Top of the ear or below?
Behind the,
Behind? What are you saying? Here? Is it here?
Yes.
Yeah, up and around, let's go.
Okay.
it's back here, right?
Okay. Then, there's little markings here. There's 3 of them. Then you want to go to what process?
Xiphoid.
Xiphoid. I'm not going to touch you. Anyway, xiphoid, which is about here. Okay, you put a tape on there so you know where you're going. Thank you. Okay, you put a tape. That's how far down it's gonna go. Okay. And then things to remember, and Professor Bethune gonna do the whole process. We're gonna check you guys off at the same time when we go into the lab or in here doing tattoos, so that you can measure on another person, check you off on that. What you will be doing in checkoff day, separate day, is doing the trachea and suction. Okay, that's, and how do we verify that the tube placement verification, what did you say?
X-ray.
X-ray first.
It can be x-ray, these are radiotape, but you don't want a patient getting an x-ray every day.
pH.
pH level. You have that little litmus paper.
They don't really do that in the,
Uh-huh.
do they do that in the hospital? I know they're supposed to.
Well, it's called pointer care. They're supposed to do the
Usually
assembly.
just listen.
Generally, you just listen. And what it is this tube is in. This is out of the body. You get about 10 cc's of air, 10 to 30 air. And you have like a syringe, a large syringe. You displace the air down into the syringe. You listen at the stomach. And you'll hear it. Okay? That's what Casabran uses. We do not do x-ray after every installation of intubation. We do the air, and we don't have point of care, so we don't do the acidity. So that is the inexpensive way of verifying. A lot of books tell us not to do that anymore.
So if you were to do it and listen and you didn't hear it, would you do it again to double check?
Okay, let me tell you some other ways of verifying, which I learned on the job.
Choking.
Okay, if you are putting down this tube, she's gonna demonstrate this. But anyway, if you're putting down this tube and someone is choking, because it's gonna elicit a cough, that's your gag. So you want them to try to relax. When you get to the back, the pharynx area, tell them to swallow. It's gonna force it down into the esophagus. That's slow. There's still some people that I'm down. You know, you got that tube going down, and you try to put the air in. You know why you're not hearing it? Because you look in the mouth and it's coiled in the back of the mouth. And that ain't good, so you take it out. If you inadvertently, you're putting the tube down and the patient's turning from action to blue, take it out. Okay. You do not want to instill any type of fluid in the lungs. You just introduced it's going to be a pneumonia. It's going to be an infective process. Okay, so placement. Casabran uses the air. A lot of your books say don't use the air, but what that facility chooses to do. The definitive to know that the tube is placed is X-ray. You can see it. It's in the stomach.
For like NCLEX, Professor Calloway, like, she really like pushes on it. She just says no initials, X-ray, after that, pH. She said that's gonna be your answer for your NCLEX.
Yeah.
No air, no nothing, just know that. For
Right. Say that again.
For your initial is X-ray, and then after that, pH.
pH. However, Pastor.
No, they don't usually do that.
But for purposes for testing, the definitive is X-ray. Okay. The different tubes, they're various sizes. Different from IV. The smaller the number, that's the small, the diameter is small. This is like a 16, 18 or 16. But there are smaller ones, which you would use for kids. Have we ever put tubes down for kids? Yes. The youngest I put a tube down was, I think it was 9 months.
So I went on a 3-month-old at work last
Mhm.
weekend. Was that?
Will you guys be doing that? No. Just adults. Okay, I'm gonna stop right there. I'm gonna have Professor Bethune come up and give you the whole scenario as to what, based on what I just said. And for test purposes for the next test, you will need to know if I describe one of these processes, decompression, lavaging, galvaging, based on the sentence I have, will you be able to determine if it's decompression? If you know that this person's roton, their abdomen, and they're nauseated, it's decompression. If it is someone comes in and they've had MBA and the abdomen is roton, and the physician says to you that I want you to instill normal saline, that's a lavage. Okay. Other things to remember is placement. What we say it was. Tip of the nose, which part of the ear? What is this called anyway? Top. Okay. I know there's one peanut and helix. Which one is whatever? You got it?
Which is where? Say it again.
Ear. And this is what? Top. She'll tell you what the terms are when she gets up here, so I think y'all can get what it was. But it's the top of the ear. Then you go down to the xiphoid process. Okay. Measuring, placement, verification, the 3 ways. The definitive is X-ray, pH, and then the air exchange. Okay. And you always irrigate with saline. It's isotonic. Okay. You ready?
Top of the ear.
So you know what I have to do for an example up here and check
Also, you measured on somebody's ear. Freddy Krueger. What they call it. What do you call it? Freddy Krueger. Freddy.
is a 16 range. You tell them what size they come in.
I told you the various sizes, but that's a 16. The bigger the number, the larger the diameter.
What I'm missing is the lubricant. Don't do that. Don't. This lubricant. So somebody will come to like, put it down without. So it's like, yeah. Water soluble, no Vaseline, no Carmex.
Oh.
Don't lick it. I like to kind of make it pliable, so I'll take it out and throw it around a little bit. I don't know what this is called, so it's the top of the ear. Okay, I know this is the lobe. Somewhere this straight is in here. I don't know where, but you're going to the top of the ear. Because you really can't see. This is like a cross-sectional visual view. You really can't see when the xiphoid process would be. So turn around. Good job. So what I'm gonna do follow directions. That's awesome. Literally. So we're going to turn this over his nose, off of his ear, let me realize what it's on, and his xiphoid process. So, notice I held that, right? So now I'm going to take a piece of tape and mark it off. So when I put it in at his nose, literally, but when I insert it, then I know to stop right about here, because it should be where it's supposed to be. Now, open wide. Thank you. Now you still patient. So if I was really going to do this on Rob, I would give him a cup of water, a straw. I would tell him that we're going to put this tube down. I would tell him why we're going to put the tube down. I need to ask him a couple of questions. One, have you ever broken your nose? Have you ever been told you had a deviated septum? Any surgery on your nose or your facial? Why am I asking him those questions?
Might not just be a straight shot.
Right. So if they have a deviated septum, I go to the physician and ask, what do you want me to do? Because that kind of alters the path. If they've had some reconstructive surgery, I need to know what. Sometimes, once I didn't even have a septum,
Oh.
I'm mad about that. But I'm like, so what do you want me to do? He doesn't have a septum. And the reason why is because of his recreational habits.
Cocaine.
So that's what it is. You can put these down early, so sometimes in the emergency department, if they've had like trauma, facial trauma, and we can't get it in the nose, we'll slide it down along the ET tube, which is, cool for us because it's only going to go in the right spot, because the ET tube is like in the trachea, so that's what we do. So we measured it, moved it up. I would tell him to tuck his chin to his chest, okay? But I will not tell him to swallow yet, okay? So we would move it, and then you would put it in, and as close as it's gonna go. Then when I think it's kind of hooked down back behind his nasopharynx. That's a real word. Nasopharynx. Then I'm gonna have him put his head up, and I'm gonna tell him to take a sip and swallow. When he swallows, I'm gonna advance. Swallow, advance, swallow, advance. And tear it up. And then when I get to this point, right here. So this should be down in may not,
Got it.
I mean,
I got it. I got it. Oh, Amy, you got a better shot.
Yeah. Just pull it out.
Okay.
So we don't ask for it?
Yeah. So,
Done.
you might be able to. I wouldn't have had it way over there either. So now somebody came up with an awesome idea, and they have these little holders that you can use to put on your NG tube. But if I need to get this tube down and I don't have time to figure out where the holders are, you can take a piece of tape. Now he's all sweaty and stuff, so I'm gonna take an alcohol pad and just put off the nose right off. And I'm gonna take it, put it over his nose. I don't like paper tape, but some people have some paper tape. I'm gonna wrap it around. What about you? Yeah, that's why.
That's awesome.
Alright, this is nice and secure on his nose. Then I'm gonna take another piece of tape and I'm gonna put it about here. I'm gonna get a safety pin. I'm going to pin it to his gown, but I'm gonna give him enough slack so if he moves around or in his sleep, that it does not come out. Because if I had to almost sit on him to get this tube in, I really don't want to have to do that again and have it come out. So how would I test for placement? Sometimes if they are really full of stuff, as soon as you put it in, you'll get immediate return. And I'm not going to instill air because I know that's who I am. But I will check the pH just to be sure. And what should the pH of gastric contents be?
1 to 4.
Alright. Then we'll hook this up to suction. If it is intermediate, how many millimeters of mercury would you set your suction can, your suction apparatus at? Intermediate suction, there are parameters. Usually someone who's on an NG tube, they will be on intermediate suction. So after lunch, hopefully you have the answer to my question.
I have it, but I'm not gonna choose.
Okay. So if you pay Sasha Will, she'll give you the answer. Also, if you have continuous suction, there are parameters for that also. You need to know what those are.
But they're typically gonna be on intermediate.
And usually they'll be on intermediate.
Especially with a Salem sump, the blue pit cap.
Where does that look into the suction guide?
What's it?
She just tell you to make it up.
Oh, she said that.
She said we better know it after lunch.
If you're gonna have tubing and tubing from your suction canister,
Oh.
this is gonna have a little, what they call it, male female little lock that goes right here. If you don't have something right here, that stuff is gonna come out. So you have a little pigtail thing that goes in here. This goes in here, and then your suction canister tubing goes here.
Okay.
And so, clarify, the rationale for sectioning stuff out is if they're just so full.
If you're decompressing, you have to get those gastric contents out, right? So you have to leave the stomach from working. So you just pull it off. If they have a GI bleed, all that stuff goes out. So whatever's in there, fluid, blood, stool, whatever's in there, it'll all come out.
And things to remember, if the person is not bleeding GI wise, bile has different colors. Bile can be golden yellow, it can be brown, it can be jade green, it can be light green, depending on the patient.
Usually if it's green though, ask the surgeon about that. He said that's the hydrochloric acid. If your patient should be MPO with this, you can tell if your patient has been drinking water because whatever the original color of the gastric contents was, it'll be like 2-3 shades lighter. And then you have all this return coming back.
Because basically you're just suctioning out whatever they put in.
Right, they don't understand that. And then they'll say, I haven't been drinking water. I'm like, really? Is you talking about the surgical suture?
Oh, no. There are some, and you're gonna hear about it more when we talk about GI, that there are some tubes that are sutured in place in the patient at the surgical site. You will not be irrigating, manipulating those tubes. It will be the physician who will, because you can then cause a further bleed.
Now, troubleshooting in NG2. If you always look at the patient first, then follow your connection, okay? If the patient says they are nauseated and you come in, you look at them, you follow your connection, and your canister is full, why are they nauseated?
Yes, every time.
So what would you like to do first?
Empty the past.
What would you like to do first? Clamp it. Thank you. Clamp it. Stop the suction. Empty your canister. Put them back up.
Yeah, so if you don't have it, it just go fly everywhere.
Yes, that's nasty. And your patient won't like you very much because then they're going to be soaked with that stuff. Now to pull it out, you have to pull it out, okay? Okay, that's contact time. Remember, this has been in through the nose and down into the stomach. What's in your nose?
Snot.
So when you take this out, remember mucus has accumulated in there. So you want to inform the patient, you want to give them a towel, and you want to make sure you kind of rein that in because you don't want that stuff flying and flinging all over you, okay? So you let Rob know you have an order. Always check your order before you go snatching out a tube. Check your order. Let Rob know you're going to take it out. You give him a towel. I tell him to hold the towel like between here and here, so hopefully they don't throw up when I take it out. But it's more or less for the nose. So you clamp this, empty your canister, pour your last whatever. You gently take it off. You tell him to hold his breath. 1, 2, 3, 1, 2, 3, hold his breath, and then you just pull, and don't be shocked by what you see on the end. And then you kind of look at it, make sure everything appears to be where it's supposed to be. Wrap it up.
Let me ask you a question. Would this person automatically go on sips and shifts when you take that tube out? No, you want to have the what to come back?
About
Well, the gag, we hope is there. The gag reflex before you give any fluids. Also, you want some bowel sounds.
So, Casablanca is easy. The center is point and click, right? When you chart. So, everything you do, you have to chart. So, we're going to narratively chart the insertion and discontinuation of this NG2. So, who wants to write it on the board?
I'm gonna pick somebody. Jason. I'm going all over the classroom, okay? And you're gonna help him write it.
We'll get there.
What's he gonna put first?
Date, time.
Or he could just put February 7, 2000. Okay. There.
What did you do? What do we do? What size?
18. It's 18.
Which narrate did I go into? Right.
Mm,
I'm gonna use that.
I think it was this one. Probably was left too.
How about this size? Insert a 16 French between NG. Into left. N-A-R-E. No, N-A-R-E. Okay. Alright, so we put it in. Did we confirm placement?
Yes.
How?
PH.
Okay. Say placement confirmed via PH. Okay.
Did you record the PH number?
Yep. PH is what?
2.
Okay. Actually, we need to put something before that. So we had immediate return of what color you want it to be?
Green.
Okay, so. So we do a little carrot top and then write that immediate return of green fluid, right?
There are 2 M's?
Yes.
Immediate return of what?
Green fluid. Not yet. Okay, placement confirmed via, pH test. Now, if we have a value, can we now call this gastric content? Okay, so now you can say, pH of gastric content 3. Yeah, we're gonna get there. Okay, did we put them up to suction?
Yes.
What kind?
Well,
Intermediate.
Okay.
I'm gonna tell you guys, it's 80 to 100.
It's not in the book.
Okay. I'll let
It's not in the book. Mhm.
Anything else you wanna say? You wanna tell them what constant is too?
Okay.
Oh, okay. Alright. Basic place on intermediate suction. Usually I put them on 80. So you can say, at 80 mm. Is it HG?
HG.
Yeah, HG. That's 80 millimeters of mercury. Okay. Now that we put them on intermediate suction, can we not measure how much we've gotten out?
Yeah.
How much would you like to say?
200.
Alright. Place on intermediate suction at 80, return of 200 ml green gastric juice. How did the patient do?
Tolerated well.
Not tolerate well. You're right, they were screaming.
Yes.
Screaming.
Yes.
Not compliant.
Yes. Patient rated. Till I work in emergency department.
There will be time where they'll, spray the back of the throat with like a CK or something.
That's
Just a lighting thing type thing. KY.
KY has nothing used to
It has other properties, please.
We're not using it for that in the hospital. If you are, I don't wanna know anything. Alright, so charting, anything with narrative charting is what happened. So, what did you find? What did you do about it? What was the patient response to your intervention? And then, is there anything you need to do afterwards? Okay? So, we inserted a 16 French into the left airway, confirmed placement via pH test, we got our reading, we connected him to intermediate suction, we removed 200 mL of green gastric fluid, and he tolerated it well. So that's how you can chart when you do your narrative chart on your paper. You guys do narrative notes like every.
When we do it, if there's something that changes.
It's something, yeah, change.
Yeah, that's what I thought.
Because in a sense, it's like you're double charting. Last semester, I understood why you have to do, why you did it. So you can get in the habit of learning how to compose a narrative note, what's supposed to be in there, and all that good stuff. Now, you're going up a little bit. Whatever you find, like I tell all my clinical groups, if you find it, it's your baby. So you walk into a patient's room, something's wrong, you found it, then we need to figure it out, we need to fix it. That's when you would write a narrative note. But for paper charting, you're gonna have to everything that you do is going to have to be a narrative note. So like your summary for the day will be narrative charting. I want to note about your assessment because I can look at your charting and see that you did your assessment. Make sense? Alright. So like if you're on tele and your patient goes from a cardism drip to PO cardism, then that's something that you need to put into your narrative charting because then you need to say how much cardism you started on. Ask the nurse, did they convert before they slow the AFib down or something? Something had to happen for them to go from the drip to PO. Make sense? So now what?
What time are they at?
We can go in the lab and I can demonstrate the suction.
Yeah, it's better to demonstrate suction.
Alright, let's do lab.
All I need to do, she'll tell you about suctioning, and then, after lunch, we'll do a demonstration on tray care, and I'll be doing that.